Okay, perhaps we'll just start. Welcome everyone to the Sowerby Philosophy and Medicine event. This is an event in the Sowerby Philosophy and Medicine colloquium series, which is organized by the Philosophy and Medicine Project at King's College London and funded by the Peter Sowerby Foundation. For this event, we're really happy to be able to welcome Roberto Fumagalli of King's College London. So Roberto has for the last 3 years been the director of King's PPE program, and his research interests span philosophy of economics, philosophy of science, moral and political philosophy, and also philosophy of public policy. And the talk he'll be giving today is entitled, "We should not use randomization procedures to allocate scarce life-saving resources." So this is some topical stuff, and we're really glad to have Roberto here today. I just want to say a couple of things about sort of general rules of engagement. I mentioned it in the email I sent out to you with the invite, but I think it would be great if we could all try to keep the camera on. It's just much easier, I think, for the speaker to sort of get a feel for the room if people keep their camera on, and it's also, you know, contributes to a more sort of discursive environment. So if you could do that, that would be great. Also, when you're not speaking, try to keep your microphone muted. And if you have any questions, there will be a Q&A portion of the talk towards the end. And if you have any questions, then please use the hand raising function. If you are unable to use the hand raising function for whatever reason, then you can drop a message in the chat and I'll put you on the list and I'll call on you, so you'll be able to ask your question anyways. And yeah, welcome everyone, and I'll hand over to you, Roberto.
Thank you very much, Ariette, and a very warm good afternoon to you all. I am truly delighted to be here with you, albeit in this virtual setting, to share some thoughts together on the use of randomization procedure to allocate scarce life-saving resources. So during the recent COVID-19 pandemic, dramatic increases have occurred in the demand for a number of scarce life-saving resources, including, for instance, ICU units, namely intensive care units. And this kind of scarcity has led a number of medical personnel across countries to make thorny triage decisions. And most of the criteria that are typically advocated for allocating intensive care units or other similar kind of medical resources typically involve a combination of different factors or criteria, including medical need to begin with, then a number of clinical factors, such as the presence or the gravity of existing medical conditions, and on top of those, also some randomization procedures, hence for RAND. Now, in the recent literature across philosophy, medicine, and public policy, a number of arguments have been put forward to support the use of this randomization procedure to allocate scarce life-saving resources. And I'll use the acronym as well for reasons of brevity. Now, the idea is that when it is impossible to divide these scarce life-saving resources among the individuals in need, or when dividing these resources will actually drastically reduce the value of these resources for the involved individuals, we should actually use randomization procedures in allocating these scarce life-saving resources. Now, in this paper, I'd like to provide a systematic categorization and a critical evaluation of the most important arguments that have been put forward in support of the use of randomization procedures in these settings. And more specifically, I want to examine together with you the following 6 arguments, and we'll see how many of these I'll be able to cover actually in the 45 minutes allocated for this talk. Namely, the argument from convenience, the one from tie breaking, equal chances, fairness, incommensurability, and indirect discrimination. And the main claim of this talk is that none of these arguments, insofar as I can see, justifies using randomization procedures for allocating scarce life-saving resources, and also will argue that decision makers, namely, for instance, the involved medical personnel, particular ethical committees, or even governmental institutions, should actually allocate scarce life-saving resources directly to the individuals who have the strongest claims to these resources, rather than actually using randomization procedures to allocate these resources. So I shall argue that we should use DARE, namely direct allocation procedures, to allocate scarce life-saving resources rather than randomization procedures. Now, before moving on, just let me specify that my claim is not that all sorts of crazy direct allocation procedures are always invariably better than randomization procedures such as lottery. I mean, we can easily think of direct allocation procedures which would be utterly crazy. I mean, think of doctors allocating scarce intensive care units just purely on the basis of racist criteria. I mean, that would be utterly, unjustifiable, and it would just be crazy. So my business here is not to defend this kind of direct allocation procedure, but more plausibly is to argue that given any allocation of scarce life-saving resources, the involved decision makers are reliably able to identify at least some direct allocation procedures which are more justified than the randomization procedures that are actually available. Now, before moving on and examining one after the others the arguments, so the structure of the talk will be quite simple. I will just basically address one by one the arguments I mentioned. Let me put forward a few preliminary remarks so as to make sure that we are all on the same page. First of all, I will speak of scarce life-saving resources to encompass a wide range of treatments and therapies that are critical to patient survival. I mean, think of organs urgently needed for transplant or some kind of organ replacement therapy, for instance. And related to that, I shall use the term randomization procedures to allocate, to indicate allocation procedures that are designed to yield specific distribution of probability among the involved individuals. Now, there are, roughly speaking, two kind of types of randomization procedures that I'm going to distinguish together with you. Some of them actually proportion the chances that each individual has of receiving the scarce available resources to the strength of the claim of these individuals, which these will be the weighted randomization procedures. And then we also have in the literature so-called fair, but I actually prefer to say unweighted randomization procedures, which actually just give an equal chance to all the involved individuals, and they stop at that stage without inquiring further into the strength of these individuals' claim to the available scarce resource. Now, that said, I mean, like randomization procedures and direct allocation procedures can actually support quite similar allocation procedures on some particular problems. But the point remains that even in those rare occasions when randomization and direct allocation, even in those rare cases where randomization procedures and direct allocation support similar kind of allocation, they are actually grounded on radically different justificatory principles. And the main difference here is that on direct allocation procedures, the strength of the claims of the involved individuals directly determines not just the chance that these individuals have of obtaining or receiving the relevant resources, but also at the end of the day, which people will actually get this particular resource. Now, this kind of outcome, namely who exactly gets what kind of resources, may be totally unpredictable in the moment we implement them. But the point is that with direct allocation procedures, the strength of the claims directly determines which people at the end of the day will get the scarce available resource. And finally, preliminary remark that I like to make. There are, of course, many possible different grounds for ascribing claims to different individuals to particular life-saving resources. Now, I'm not in the business here of developing a theory of claims, namely of listing exhaustively what kind of reason may ground claim, or actually how exactly each factors that you could possibly think maps on the strengths of individual claims or to these particular resources. For my evaluation, the all important thing, the all important distinction we need is between generic reasons for wanting to receive a particular resource and actual claim to that resource. And the basic idea here is simply that not all reason that anyone could possibly have for getting one of these resources constitutes a claim to such resource. For instance, if I just badly happen to want to get some particular resource, this want by itself is not sufficient to grant a claim to this particular resource. and maybe more distinction will come in the sections to come. But that's insofar as stage setting is required, I would say. And I'd like now to proceed one by one to consider the various arguments I anticipated before. So let us start with the argument from convenience. This argument claims that we should actually use a randomized procedure, randomization procedures, to allocate scarce life-saving resources on the alleged ground that designing and implementing these randomization procedures is less costly and time-consuming than actually designing and implementing direct allocation procedures. Now, I will use as many colors as possible to keep you awake, because I realize that online presentation can be incredibly kind of sobering on that point of view. So I'll try to keep a live presentation style as much as I can. Now, the main idea behind this kind of argument from convenience is that acquiring the information that we would require in order to establish exactly which candidate exactly have the strongest claims is actually expensive and time consuming. And the main advantage of a randomization procedure is they actually avoid all the cost of deliberate selections. And you find a couple of references for this argument for all the arguments I'm going to see in the coming minutes. Now, I have two reasons actually to doubt that this appeal to convenience consideration by itself justifies using randomization procedures to allocate scarce life-saving resources. First, I think that convenience consideration by themselves rarely justify using randomization procedures, because the point is that there are plenty of possible different randomization procedures that you could possibly use for any given allocation problem, and establishing exactly which of these randomization procedures we should adopt, just think of the difference between unweighted and weighted randomization procedures, actually require us to determine the strengths of the claims and how exactly differences in the strength of the claim bear on the justifiability of randomization procedure as opposed to other sort of, for instance, direct allocation procedures. And secondly, I think that convenience is not the only factors that bear on the justifiability of randomization or direct allocation procedures. I mean, the point is that even in situations of dire emergencies like the one we had in the first wave of COVID-19, decision makers typically have the time and the resources to assess at least some of the factors besides sheer convenience that actually bear on the justifiability of different allocation procedure. I mean, just even think of the first wave. In the most terrible moment, they were not actually randomizing between them. They were actually evaluating at least the medical need of the individuals involved and some kind of expected speed and chance of recovery. Now, for each argument, I will go briefly through some kind of potential objections that you may have, and I'll try to address them the best I can. Now, suppose you're a proponent of this argument from convenience, you could tell me, well, Roberto, go slow here, because namely direct allocation procedures are simply not convenient because the difference in the strengths of the claims of different individuals is just too small compared to the obnoxious and enormous cost that we would have to actually bear in order to obtain the relevant information which is required to distinguish between different individuals. And the problem with this objection, I think, is that the allocation of scarce life-saving resources, which is the specific subset of resources that I'm targeting, have crucial life and death implication, which typically trump the cost of acquiring additional information that is required to identify the strongest candidate. Now, you may further object that randomization procedures are still convenient because they actually relieve doctors of the responsibility of having to decide who lives and who dies, and of the associated emotional burden, which could actually be dramatic and is typically left on the shoulder of the medical personnel. And again, I think that I don't really see how the use of randomization procedure rather than direct allocation procedure will solve this problem, because whatever decision the medical personnel will do in those sort of situations, even if they are using a randomization procedure, will still make all of the difference between life and death for all of these individuals. And on top of that, I think that appealing just to the consideration of psychological benefits that are putatively yielded by randomization procedures rarely trump, once again, the significance of the life and death implication that the difference in the strength of the claims that are involved in this dramatic situation typically have for the allocation procedures at end. And at the end of the day, I think that randomization procedures do not actually exempt the doctors or any other involved ethical committees from the burden of responsibility here. In fact, one may argue on the contrary that using randomization procedure at some stage actually is a kind of, amounts to relinquishing the responsibility that they have to make the best and most informed possible decision for the patients they are actually treating. Now, let me move on the second argument, the argument from tie breaking. The argument from tie breaking claims that we should actually use randomization procedures to allocate scarce life-saving resources on the alleged ground that randomization procedures are good tiebreakers, which means effective means to just get the decisions done when the claims of different candidates are actually exactly or roughly exactly balanced. The thought here is that when different individuals have equally strong claims, decision makers should actually use randomization procedures rather than direct procedures to allocate scarce life-saving resources. And as before, I have at least a couple of reasons to doubt actually that this kind of appeal to tie-breaking consideration actually justifies the use of randomization procedures to allocate life-saving resources. The first reason is that decision makers are not always able to establish whether the claims of different individuals are actually exactly equally strong. And the point is simply that strength depends on multiple factors, and the impact on these factors on the strength of different individuals' claim is frequently hard to assess to the extent that will be required to establish whether the claims are actually equally balanced. Just to give you an example, and these are considerations that may potentially complicate also the identification of the correct identification procedure. But just to give you an example of how this kind of distinction works, I mean, we presumably all agree that all the different individuals have at least a generic claim to life in these sorts of life-threatening situations. But this fact by itself falls short of implying that all the different individuals also have equal claim, not just to life generically, but to the specific life-saving resources that are actually allocated in this particular situation. And the other reason I have for doubting this argument for tie-breaking consideration is that actually when we are able to actually assess the claim, we will find that claims rarely have exactly equal strength. And just think of all the potential ways in which the relevant people may differ, from differences in terms of medical need, the likelihood or the expected speed of recovery, and so on. And this fact by itself already casts out on the potential of tie-breaking consideration to ground a wide range case in favor of randomization. The idea will be that even if the argument works, it will work only in that very narrow subset of situation where really the claims are equally strong and there are not so many cases around which are actually like that. Now, suppose you're a proponent of this argument from tie-breaking. You could object again to what I just said and tell me, well, if one allocates scarce life-saving resources directly to some individuals rather than others without running a lottery, let's say, one is actually treating, as a matter of fact, some lives as more worthy than others. And again, I think that one may consistently hold that individuals' lives are equally worthy, but this has no direct implication as to whether the claims that these individuals have to the specific life-saving resources we are targeting in a specific context also are equally strong. They are arguably connected kind of issues, but they are still conceptually distinct. A further objection here will be that in spite of all I said so far, the decision makers may be able to narrow down the set of relevant candidates so much that they are actually practically indifferent between them. And I think, however, that whenever decision makers can identify residual differences in the strength of the claims that different individuals have to the particular resources we have, we can guess that, I mean, carefully designed direct allocation rather than randomization procedures are more likely than these randomization procedures to allocate the scarce life-saving resources available to individuals who have comparatively stronger rather than weaker claim. And in any case, individuals on average who have stronger claims than the claims that they would have if they were just merely selected randomly. Let me now consider the third argument, the argument from equal chances. The argument from equal chances holds that we should use randomization procedures to allocate scarce life-saving resources on the alleged grounds that when individuals have equal claims to scarce life-saving resources, justice itself demands that each of the involved persons should actually receive an equal chance to get these particular resources. The idea here is that randomization procedures have the unique capacity to divide available goods probabilistically and to substitute equality of outcomes with equality of chance, which is a surrogate satisfaction and the best possible form of equality that we can actually allocate to individuals in the tragic situations that we are actually facing. And as I did in previous arguments, I think I have a few reasons to doubt that appealing to this equal chances consideration justifies the use of randomization procedures rather than the best available direct allocation procedures that we actually have. Let me expand on a couple of reasons in turn. First, as I just said with regard to the previous argument, individuals' claims rarely have exactly equal strength or even roughly equal strength. And this in turn casts doubt on the potential of the argument to ground a wide range case for randomization procedures. But even barring this kind of a domain of applicability considerations, I really think it's hard to see in what chance exactly chances of satisfaction would constitute surrogate satisfaction in such a way that giving equal chances to individuals rather than the actual good to which they putatively have claims is a way to treat these individuals fairly. In other words, my thoughts is that the chances that randomization procedures actually give to the various individuals involved do not benefit all the involved individuals in a way that makes it better for them or even rational for them to prefer that the randomization is actually chosen rather than the best available direct allocation procedures. Now, there are again some objections here I think I want to face actually to preempt potential questions you may have in this respect. And one, I think, obvious objection here is that while differences in strengths between different individuals are typical of minor axiological relevance compared to the allegedly crucial importance that giving each person equal chances has in this tragic situation. And I have a threefold reply to this intuitive objection to my claim. First, I think that allocation of scarce life-saving resources have life and death implication whose relevance trump, especially when these kind of differences are quite large, the importance, however large it is, of giving equal chances to different individuals. Because if these different individuals have claims of different importance, the importance of giving them equal chances comparatively decreases, and actually the importance of this life and death implication becomes comparatively more prominent. Secondly, more on the conceptual side of things, I think that the chances that randomization procedures give to different individuals are not by themselves like additional goods that should be added somehow to the expected utility of being saved or the expected benefits, if you may, that each individual has of being saved in this situation. And more generally, and this is an issue targeted already by Wasserman in a nice paper in Economics and Philosophy more than a couple of decades ago, it is just not generally the case that the chances of benefits is itself a benefit. And now get me right on this point. I'm not denying that the individuals involved could rationally or plausibly actually ascribe intrinsic relevance to these chances in specific situations. What I'm saying is that it's up to the proponents of this argument that they can generally do that, and I just don't see how they could actually pull this conclusion from the evidence or the conceptual considerations that are out there in the literature. Namely, there is no way for them to say that it's generally the case that chances of benefit should be regarded as a benefit, even by the people actually designing and implementing these lotteries. I think I'm halfway more or less through the different arguments, so I hope that you can still resist and bear with me with regard to the final three arguments that I like to see together with you. So the argument from fairness then. So this argument holds that we should actually use randomization procedures to allocate scarce life-saving resources on the alleged ground that randomization procedures are fairer than direct allocation procedures, and actually at times are the fairest way of distributing the goods that we have available. The thought here, and is famously associated with John Broom's actually theory of fairness that he actually elaborated in a series of papers from the 80s and the 90s, is that fairness requires that each claim of the involved individuals be satisfied in proportion to the strengths of these claims. So it's a relative assessment of comparative strengths of the claims of the involved individuals in particular allocation procedure. In a nutshell, the idea is that when the strengths of the claim of all the involved individuals is exactly equal or roughly equal, we ought to use an unweighted randomization procedure because it just gives everyone equal chances. When the strands differ, we actually should use a weighted randomization procedures whose weight actually reflect proportionally the strength of the claims of each and all the individuals who are actually involved. And again, I'm not convinced that this argument can ground a wide-ranging case in favor of using randomization procedures to allocate life-saving resources. Let me again expand on two reasons in turn. First, as actually Broom himself aptly acknowledges, fairness is not the only factor to consider in this situation. It's one important consideration among many other considerations. And for all the arguments and the series of contributions that John did, I think, fairness considerations may frequently fail to trump other important factors. And I'm here thinking of at least a couple of different sets of factors. On the one hand, we find social goods, so super individual factors, so to speak. And on the other hand, we find also individual or intersubjective factors, such as differences in terms of medical needs and or in terms of likelihood to benefit. And then secondly, and I think more poignantly, is that the argument does not show that randomization procedures are actually generally fairer than direct allocation procedures. For the point is that individuals rarely have equally strong claims for that. And in particular, the point is that when the strengths of the claims of different individuals greatly differ, so think of individuals who have radically different claims and claims which radically differ in terms of strength, it would actually be positively unfair to allocate these life-saving resources using a randomization procedures rather than at that point directly allocating these resources to these individuals whose strength ex hypotheses are much stronger than the claims of their competitors. Now, there are a couple of replies that if you're either Broom or some of the proponents or friends of this theory, you're likely to put forward. The first objection is that, well, decision makers, dear Roberto, can actually track the strengths of the claims by means of weighted lotteries. I mean, that's exactly what weighted lotteries are for. John could tell me and say, look, we use this lottery to track the fact that the claims of different individuals may actually vary in strength, and that's why we use them. And I'll just reply with the quote that I think nicely represents what myself I would reply in those situations. I mean, suppose that there is only you and me, and we are just two different individuals competing for an intensive care unit. And suppose that your claims are much weighted than mine, namely much stronger, namely you would actually need that kind of intensive care unit much more than me. You would actually benefit from it much more and much more quickly than me. You got COVID because I infected you, because I routinely flouted socially distancing regulation, and I've just went for fun to some of these silly COVID parties. I mean, at that point, honestly, is there really any unfairness? If you directly get this bloody good and you let me not have it, rather than running a randomization procedure, which maybe gives me just 10%, let's say, of getting the good and gives to you 90%, maybe we run it and it comes out that I received the good on top of that. I think that outcome will be massively unfair for any kind of plausible theory of fairness in that respect. And I really genuinely think that my point here holds across many different theories of welfare. Of fairness, sorry. And the second objection you may have is that the argument at least must justify using a randomization procedure unless claims are strongly unequal, like in the putatively extreme case I just outlined to you. And even then, I think I would have a couple of replies here. First of all, well, if you really go for that kind of objection, you're really watering down a lot the domain and the scope of application of this argument from fairness. Basically, we'll just apply in those cases where the claims are really close to be as good as each other. And on top of that, I think that there is an additional difficulty for this objection, namely that this kind of objection, if it is to fly and to justify the argument for at least a decent number or proportion of cases, should give us some clear criteria to establish when exactly it is justified to use randomization procedure rather than direct allocation procedure. And the problem is that neither Broom nor a subsequent kind of contribution to the literature on this topic, I think, provided us with clear criteria to establish when exactly the difference in the strength of different individuals is small enough so that putative fairness gains that are allegedly provided by randomization procedures would actually trump the unfairness which would occur if we run the lottery and the weaker claims actually get the good. So think back of the example I just given. I mean, that's a clear example, I think, where, I mean, like the claims are so different from each other in strength that if we run the lottery and I happen to be lucky and you unlucky and I get the intensive care unit, gee, that's just unfair. And you need to provide a clear criteria in place to establish when exactly we surpass this kind of threshold, however vague they may be, to actually enter this kind of zone when it's not actually justified to use a randomization procedure at all. Let me proceed to the final 2 arguments in the last 10 minutes of the talk, and then I think I'm just in time actually, Ariette. So let's see how it goes with that. Let me consider now the argument from incommensurability. This argument claims that we should use randomization procedures rather than direct allocation procedures to allocate scarce life-saving resources on the alleged ground that it's often impossible to weight different individuals' claim, and by weight I mean compare in strength, just that we get clear, in any precise way. And the thought is that the strength of different claims to scarce life-saving resources might simply be incommensurable. And wherever options are incommensurable in that way, because let's say there are different individuals' life at stake, is excruciatingly difficult to weigh the different factors here. Decision makers should actually allocate scarce life-saving resources on the basis of randomization procedures rather than direct allocation procedures. And as I did before, let me provide some reasons why I think that this appeals to incommensurability, at least by itself, can actually ground any wide-ranging case for randomization procedures. I have 3 replies in this case. First, I think that showing the strength of different individuals' claim is actually incommensurable, requires the proponents of this argument to actually show that the strengths of these different claims, namely these comparisons, are actually impossible, not just costly or inconvenient or difficult or somehow hard to draw. And for all of these authors actually argue, I think that they fail to show and to address this kind of justificatory challenge already by itself. Secondly, I think that the difficulties that are admittedly involved in assessing the strength of different individuals' claims do not actually prevent at least informed and, for instance, ordinal rather than cardinal judgments of strength. And just think of what the doctors did even during the first wave when they were drawing judgments of medical need. These were fallible judgments. They were absolutely not cardinal judgments or any kind of hyper precise metric. Actually, they were often quite crude given the extreme pressure under which they were, but they were still able, I think, to reliably draw a number of interesting ordinal judgments, which are contestable, which are fallible, as I say, but even in those cases of extreme emergency. And third, I think that deciding which randomization procedure actually to use, even think of weighted versus unweighted randomization procedure, will still require us to assess the strength of different individuals' claims, even in those situations when we are using randomization procedure. And if that is the case, while pointing to the difficulties, not to mention the alleged incommensurability that is involved in assessing the strength of different individuals' claim to the scarce available resources, does not per se license regarding randomization procedures as more justified than actually direct allocation procedures. In fact, it could easily be against both randomization procedures and randomization procedures if these kind of incommensurability constraints are as systematic and widespread as the proponents of this claim actually allege. You may have an objection here as well, and I'll try to preempt this as I did in previous cases. This, I think, is an interesting variant by a friend and colleague of mine, Tiny Sun. You could actually object, well, when an agent is actually unsure as to what the morally right allocation is, then perhaps in those cases, using randomization procedure is just the best that we can do, given that we are morally uncertain, I mean, given our own moral uncertainty. And I have a two-pronged reply in this respect. I think that, well, even if it works, these actually support randomization procedures only, again, when it is epistemically impossible to identify the morally right allocation, and actually Nissan aptly acknowledges this point as well. And the point is that once you acknowledge this, however, this greatly limits the potential to ground, again, a wide-ranging case in favor of randomization procedures. Because in many cases, decision makers can resolve or at least alleviate the moral uncertainty that surround this thorny situation by acquiring more kind of information about the agents. And this happened even during this first wave of the pandemic, just to give you an example. And you may wonder what kind of information they may possibly acquire. Well, I have in mind here a series of different information that may be available. For instance, the feasibility of different randomization procedures and direct allocation procedures, depending on how much time you have to make the relevant decision. The kind of consequences of different allocation to different individuals, depending on these individuals' medical characteristics and features, and the value that different moral kind of normative theories assign to different allocators. So there is plenty of different information that the doctors or the ethical committees could, and actually, as a matter of fact, typically do acquire in order to alleviate this kind of moral uncertainty. Final argument, the argument from indirect discrimination. And this will conclude at least the main argument I've been able to think of. And I'll be grateful if you can suggest actually additional argument, because I should add this is the first time actually presenting these papers. And I'll be all the more grateful actually if you can suggest avenues for putting pressure on my arguments that I couldn't think of. Now, this argument from indirect discrimination holds that we should use randomization procedures rather than direct allocation procedures on the alleged ground that direct allocation procedures are often indirectly discriminatory, whereas randomization procedures can at least ensure that bad reasons are just kept out of the decision and they actually exclude unjust influences. The idea will be that randomization procedures are generally less vulnerable than direct allocation procedures to biases. And there are plenty of examples here. Some of these examples pertain to a number of horrible direct allocation procedures that you could think of. And I gave myself some example of those. Think of racist allocation procedures, homophobic allocation procedures, and you name what. But on top of that, there are also ways in which allocation procedures can be disturbingly discriminatory in indirect ways. And I'm also willing to grant that. I mean, think, for instance, of direct allocation procedures that tend to adversely affect disabled or otherwise disadvantaged individuals because of factors that are actually unrelated to their medical condition in situations where medical condition should be the foremost kind of consideration at hand. So this argument, I think, has some pull at least because we can easily think of a number of direct allocation procedures that fall in the grip of this argument. The problem as before, I think that there are also plenty of direct allocation procedures which actually escape from this kind of consideration. So let me provide you again some reasons I have for doubting that this argument would license any kind of generic or general objection to use direct allocation procedures. First, and I think this is an important distinction to draw here, not all factors that happen to make a difference to allocation are unjustifiably discriminatory. I mean, otherwise there will never be any point by definition to use direct allocation procedures. And to give you an example, let me give you an example that was actually quite heavily debated when it came out that in Italy, I mean, country where I'm from, and a number of other countries, the medical personnel made the thorny 3-age decision based just on the sheer age of the individuals at the very peak of the first wave of the pandemic. Now, many people complain that directly allocating these intensive care units just directly in terms of age is unjustifiably discriminatory. And I actually personally tend to agree with it, even though it's not partly of my own argument here. However, there are other ways in which we can think that allocation procedures can actually indirectly disfavor the elderly, which I think, however, are not discriminatory in this manner. So for instance, suppose that we could grant allocation procedures based on the capacity to benefit or the capacity to actually improve after the illness and quite rapidly so that you can free the intensive care unit for other people as well in times where these resources are really scarce. This obviously would predictably disadvantage the elderly compared to the healthy and the young, but this I think does not per se make allocation and this kind of allocation criteria unjustifiably discriminatory. I mean, you may disagree with this specific example and with my intuition here, this is just an illustration, okay? But the point I hope it still holds, namely that, well, we may want to provide direct allocation procedures and not all of these that are actually succeeding in discriminating between different individuals are unjustifiably discriminatory. And secondly, I think we should really focus on whether a randomization procedure perform really much better than direct allocation procedure on this discriminatory point, because the mere fact, first of all, that discriminatory biases may and actually do bias, I should add, some direct allocation procedure does not cast general doubt on the justifiability of direct allocation procedure. because there are a number of ways in which direct allocation procedures can actually alleviate or even block a number of biases. I mean, there are in fact a number of blinding mechanisms for all direct, or the most used at least, allocation procedures that actually enable the decision makers to avoid allocation, which are actually grounded on criteria such as people's ability to pay, at least if a system is not corrupted, but more on this in one slide from now, or ethnicity consideration or sexual orientation consideration, which is to say, we can of course think of many bad direct allocation procedures, but we can also think, and there is a literature on this, on how we can actually screen off the obnoxious influence of some discriminatory biases on the direct allocation procedures we employ. Now you may have an objection, and I'll conclude on this one with a final recap at the end, that despite all that I said so far, randomization procedures are surely much more effective than direct allocation procedures in preventive decision makers from engaging in arbitrary exercise of power, and even in preventing the candidates themselves in surreptitiously trying to make themselves more eligible for cure at the cost to themselves or to society. I mean, think of, I don't know, candidates deliberately infecting themselves with COVID, or actually altering their own behavior in such a way that they can fit better the announced criteria. I have 3 replies on this point, and then I'll conclude. First, I think that randomization procedures are not always less vulnerable to biases than direct allocation procedures. In fact, I think that some kind of biases can demonstrably influence both the design and the implementation of randomization procedures, and just think of situations where you're actually needing to decide how exactly to calibrate the weight. You are still back again to consider how much different individuals claim differ from each other. And if you go for just blind unweighted lottery, they're just implausible because they would ignore a number of certainly relevant difference between different individuals. And even the judgment as to whether the condition for justifiably using randomization procedures in the first place can actually be biased by, for instance, racist bias at this point. Which is to say, if you're really that worried that these indirectly discriminatory biases are so relevant, well, then you better check that they are not actually also relevant against randomization procedures in the very same way, or at least to a very similar extent to which they're actually biting against direct allocation procedures. On top of that, I think that the outcome uncertainty, and I would say the extreme outcome uncertainty associated with randomization procedures, together with the indirect relevance that the strength that different individuals claim have on the actual final allocation, in a way, yes, it can screen indirect discrimination influences, but it also removes the ability of the decision maker to provide incentives for desirable, for instance, responsible, prudent, other regarding behavior. And in this respect, I think at least that the decently designed direct allocation procedures may be calibrated in such a way that they actually directly incentivize desirable behavior. Now, I won't spend more than a few seconds on this point because of a controversial example, okay? So I tend to try to behave as much as I can in a very responsible manner in public places, but I can tell you that whenever I go around, even for a walk with my super strong mask around in the area and staying away from all the individuals I encounter, many individuals are not behaving like that. And one of the factors I like to be included when the resources will unfortunately become scarce again is how did these people behave, and did they deliberately expose themselves with very little cost of a prevention measure to the infection of COVID. And one way I think in which some kind of allocation procedures might be designed is to actually make them sensitive to the way in which people behave actually and make themselves more or less likely to get this particular illness. I mean, this is obviously, incredibly difficult to implement, but I'm just putting this point for consideration, just to show that if there were ways to design our incentive schemes in this way, this would have a massive impact on people's behavior, and I would argue would have a massively beneficial outcome and impact on society at large, and would actually possibly avoid us a second lockdown, for which we are unfortunately headed. Now, let me conclude now, and I think I'm right on time there, Ariette. So in this short presentation, I examine what I regard at least as the most influential argument that have been either to put forward to support the use of randomization procedures for allocating scarce life-saving resources. And I've argued that none of these arguments actually justifies using randomization procedures. Now, this result by itself does not exclude the possibility that some further argument I could not think of may actually support specific randomization procedures. But I think that it makes it pressing for the proponents of randomization procedures to articulate and also support what these arguments exactly are. And in the absence of these arguments, I do think that at least provisionally, insofar as we know, the decision makers should actually allocate scarce life-saving resources directly to the individuals with the strongest claim to these resources, rather than use randomization procedures to allocate these resources. And on this note, I conclude, and I genuinely think that our brains and heart should come before lottery in this respect. Thank you so much for the attention.
Thank you so much, Roberto. That was great. We've got plenty of time for questions, and yeah, as before, just raise your hand, and I will call on you. So I think we've got start with Joseph.
Hi, Joe Millam from the National Institutes of Health in the US. Roberto, thanks so much for this talk. It's really fascinating. So I would like to push you a little bit on one aspect of what you're saying, which is that I wonder how much you are overconfident about our ability to identify the principles by which we should directly allocate and how those principles should be weighed against each other. So take the sort of situation that arises not infrequently in hospitals here. We have a number of patients who are eligible for remdesivir and are experiencing symptoms of severe COVID-19 disease. We have some differences between them that we can identify, right? So some of them are slightly older than others by a few years maybe. Some of them are more disadvantaged than others, right? Which we can identify by the communities they come from, other markers of socioeconomic status and so on. Some of them have comorbidities that we think predispose them to do worse, right? So lots of factors that we have some reason to think will affect how they do. We have some reason to think are relevant to claims of justice that they have, but are not, don't make a huge difference either way, right? It's a small difference in expected benefit, or it's slightly more disadvantaged than someone else. Now, confronted with a choice between two such patients, on your view, we are supposed to identify how to directly allocate by looking at who has the greatest claim. And we're supposed to be able to say, well, prospective benefit matters this much, degree of disadvantage of this sort or this sort matters this much. Here's how we combine those considerations. This is the ranking we come up with when we're looking at these specific patients with these characteristics. But I think for a lot of people, and certainly for a lot of clinicians, when they see individuals who are roughly similar in those ways, and whose claims, if they differ for different reasons, they would say the fairest thing to do is to choose between them randomly, precisely because we don't know which one should get highest priority, because we don't have the answers to these really difficult ethical questions.
Yeah, great. Thank you so much for that, Joseph. For a number of reasons, I would say. First, because it comes directly from practitioners. And I think there will be limited point if I come up even with a nice theory which remains confined to the ideal world of ideal theories without having any direct and reliable implications for our actual medical practice. So thank you so much for that, but also thank you for the extreme clarity with which I think you distinguish a number of critical junctures in this kind of difficult evaluative exercise. First of all, I mean, one reply one can say that I might be guilty of a philosopher's professional deformation, which tends to generally basically overestimate the amount of relevant reasons we can identify over the set of all relevant reasons. I should add that the project I'm presenting today can be seen as the preliminary stage and a wide-ranging general stage, on top of which more specific projects could actually and should be developed, I think, for addressing specific allocation procedures for specific kinds of good. the reason simply is that, and if you look at the presentation I given, I didn't provide you any metric. I didn't provide you with any list of these factors. In fact, I said explicitly at the beginning that I'm not in the business with this particular paper to provide those kind of criteria. Well, first, because I would have to be much more competent, for instance, with dealing specifically with COVID-19 cases than I actually am just purely from a medical procedure. But on top of that, because I think that even having that kind of medical competence will require a lot of contextual sensitivity and pluralism when it comes to what kind of criteria may matter. And I say this because the criteria that exactly are going to matter and the relative weights may actually vary depending on which specific scarce life-saving resources we have. I mean, we may undergo a number of interesting evaluation and contestable weighting when it comes to intensive care units. I was contacted by other academics, what should we do with vaccines rather than intensive care units? And there is no reason to think that the list of relevant reasons and the relative weights will be exactly the same for vaccine as with intensive care units, because the trade-offs and even the set of relevant reasons may actually vary there. Now, that said, let me expand on a couple of points where I think that I would like to bite the bullet in this sense. Yes, there definitely are limitations into the amount and number of reasons we can identify, but this by itself does not detract from doing really not just the best we can, but presumably to devote more resources than what we are actually doing, at least in many cases, to the identification of the best patients and the patients with the strongest claim. Now, the extent to which we may be able to do that, coming back to my point between ideal and non-ideal theory, may admittedly vary. I mean, if you are in the middle of a first wave pandemic, there may be a really limited way, and after we actually apply the few criteria, we may actually run out of identifiable reasons. And in that point, I would be willing to grant your point. But out of a first wave of a pandemic, when we had, for instance, an entire summer to think very carefully what we ought to do when the situation arises again, and unfortunately we were in the position to predict that it would arise again given the way in which our societies are structured, then I think that much more effort and resources than what actually has been done, I think, should be allocated and invested in finding what exactly these reasons are. And I'm not necessarily advocating here, I should add, a model of a philosopher's lead. It's actually an interdisciplinary kind of venture where the doctors must sit actually together with policymakers and philosophers in making these decisions. But to close, I also want to point to a reason why I think that it may actually be the proponents of randomization procedures here that are actually quite overconfident in actually their ability to say that we actually run out and we have actually identified all relevant reasons such that it's actually appropriate to resort to a lottery. And in this respect, I think that advocating lotteries, namely randomization procedures, would have pernicious implications for the medical profession as well, because it would actually inadvertently incentivize people to say, well, we actually ran out of reason a little bit before actually they came to the point where they really ran out of the relevant reason. And perhaps in some of these cases, they should have thought more profoundly and more deeply into the kind of trade-offs that we're actually facing, to an extent that they went randomly, so to speak, a bit too early. And in that sense, it was unfair to all the individual claims that were involved, whose claims are actually stronger than other individuals.
May I quickly follow up?
Quickly, yeah, sure.
It's Ariette who manages, yeah, I'm not in charge.
Thank you. So you mentioned a lot of really important and interesting points in that response. So I just want to follow up on one, which is, again, it sounds as though you're now making your arguments conditional on us identifying the right theory by which we can directly allocate. And you suggested that maybe we should have spent the summer working out what that theory is. But I actually think that we've spent, decades in this form and in other form, hundreds of years, arguing about what the right theory of allocating goods is. And we don't seem to have come up with the answer. So if your conclusions are conditional on us being able to come up with the correct answer in ideal theory, then it seems that we're going to have to stick with randomization in quite a lot of cases while we wait for that progress to get made.
Thanks, Joseph. Great again. I will bite the bullet again on that, on at least two grounds. Well, first I should say, it's very interesting because in parallel to this project in philosophy of medicine, which actually is this one that I presented is my most recent project, I have to say. I'm working on another project on the science of well-being. And one of the objections I'm actually dealing with is exactly this one, because I'm one of the advocates of a reformed division of labor in the science of well-being, whereas philosophers actually do provide theories on well-being that ground public policy. And the picture I have in mind is interdisciplinary in this case, because medicine is outside the realm of expertise that we do have, but parallels in many ways on that. And exactly one of the objections you face there is, gee, but you philosophers kept disagreeing with each other for centuries, and why should we relate on you rather than some other alternative solution? Now, in that case of well-being, the alternative solution would be the empirical science, such as neuropsychology. In this case, the alternative solution would be randomization. And in this case, I generally really think that it will be, first of all, too quick to say that given that we disagree, then, I mean, theories are not of help to us, because the mere fact that we disagreed so much in the past and we disagree in so many cases is a far cry from saying that all theories are on a par, or that there are no ways of discriminating between some of these different theories. In fact, we could use medical case studies to actively discriminate between different philosophical theories. The conclusion will, yes, be contestable, will be fallible, but is still a much stronger claim, I think, to claim that, you know, all theories will be equal, or to an extent that will actually render at that point randomization preferable to relying on theories, or even our best available theories, or at least the kernel of all of our theories that are actually converging on those particular cases. So I still think that the onus of proof will be on the shoulder of the proponents of lotteries to tell me, look, the disagreements between the best available theories are so systematic, even in those cases that there is no convergence, there is no other solution, or the most reasonable solution really here is to go for a randomization. And I do not think that if we adopt that approach, the actual realm of application of randomization procedures would actually be that wide, apart from those admitted situations of a dear emergency, like the first wave, where we are actually running out of time and not just of reason. And if you wait just a few minutes more, one of the patients dies.
Thank you.
Thank you so much again.
Okay, great. So Jill's up next.
Thank you. I'm also coming in from the United States in Massachusetts, Amherst College. I'm in the philosophy department there. I want to thank you for your paper. I thought that you did a beautiful job responding to the objections from a philosophical point of view, right? What is the most reasonable approach? And I also agree with your sense that our inability to make these distinctions has been greatly overestimated, and the fact that it's difficult to come to any kind of agreement doesn't show that we don't have some strong grounds for preferring some criteria over others. But I think I do want to press with the point that Joseph Millen made earlier, is the kind of messiness that happens when one tries to apply an ideal theory to an imperfect world. And I'm thinking of the United States currently. In Massachusetts, the Department of Public Health came out with guidelines for allocating scarce resources in March, and it has been revised twice over the last several months, mainly in response to social rights concerns of different populations in the United States. And I'm wondering whether, I'm not sure if this is a separate objection, that kind of thing that you were looking for, but one concern I think that has motivated the changes, and the changes have gone toward more randomization against the earliest draft, which I think had a lot of bioethicists being part of it. And I think it moved toward a more randomization because in a society like ours that has been characterized by deep injustice, racial injustice, and also I think what motivated the most recent draft is concern about discrimination against the disabled and assumptions that the quality of the life of those who are disabled is not as great as those who lack disabilities, that there's a great deal of suspicion on the part of our population against those in authority to make those decisions in ways that are unbiased. And so even if you were to say, well, we can come up with certain kinds of veils of ignorance that would ensure that those sorts of factors didn't play in a role in our decisions. I think that our population would be rightly suspicious of our applying those policies in a unbiased manner. And so from a public health point of view, one additional factor that might be important to consider is whether it has the buy-in of the citizens within that community, that the procedures that are being applied are going to be applied fairly. And so they might think that, maybe what you're saying is the first best, but in a society like ours characterized by injustice, we have to rely on a second best of randomization to at least ensure that all of us have a fairly equal shot at access to scarce resources.
Thank you so much, Jill. Great question again. Let me provide a three-pronged answer, and then we see how we move from there. Well, the first is actually a thank you, actually, and also a request if it would be possible to actually send me these kind of procedures that were actually proposed, both the original version and the updated version, because there is one clear thing that one of the aims that I have, at least, as I said, yes, this starts from an ideal kind of theory perspective, but it wants to land sooner rather than later on non-ideal kind of theoretical scenarios, which means that the ability of my case to fit the actual practice of practitioners or ethical committees is one of the requirements against which I have to judge the merits of my own proposal in that respect. That said, I'm not saying necessarily that will be evidence against my account. It will be evidence if it had to be systematic, occasional instances of revisions that go towards randomization rather than direct allocation upon reflection. Can mount some pressure against my account, but I might also want to say that, my account may provide reasons for doubting before revising in that kind of direction. But I'm glad to know, at least, that there has been iterative revision of those kind of guidelines in a way that can directly impact on the extent to which we rely on randomization rather than direct procedure. It just happens to go, I think, in exactly the wrong direction. But, and with this, I come to my second and third point. I'm not so sure I'm in the position to say, given any particular socioeconomic context, and especially the currently divided US, given also the racial and politically related turmoil, whether my this kind of target application fits sufficiently well the ideal or not so ideal scenario that I've been drafting so far. But a couple of things I want to say is, first of all, I should say that, there still are criteria, even in deeply divided situation, when there is this widespread suspicion, for opting for a transparent public debates about these criteria. It's not an element on which I actually put a lot of emphasis so far, but what I'm advocating is not necessarily a pool of top secret experts that, unbeknown to anyone, they close in a particular ivory tower and they list down these criteria, writing some crazy third order function to map them, and they deliver just the results out of people perhaps using some kind of AI machines. What I'm really advocating is an open and public discussion about these criteria, which of course is likely to enrage many and not convince others in a spec, but I think is still much more superior to what will be to either go for a top secret kind of evaluation, which is occasionally, by the way, done within hospitals and ethical committees without informing the relatives, let's say, of the patients. And at least this happened in Italy, for instance, during the first wave COVID pandemic, which I think is despicable on its own. And secondly, will still be better than randomization procedures. And in this respect, I would say the following. If the situation is so desperately non-ideal, namely so desperately divided and run with suspicion among the involved parties, would the targeted individuals really trust that the decision makers would design and implement the lottery and this randomization procedure in such a fair manner? Because I think that some of the objections that one could raise against my case look really like objection until one actually starts taking into proper account that if one really buys into the objection and keeps it in the picture, that's also a reason for simultaneously discounting the merits of randomization procedures. And once the level is really fair, namely, we are judging my proposal under the same non-ideal circumstances, well, then I'm not so sure that these are really objections that are holding more against my proposal rather than the randomization procedure. And this is wonderful parallel, I should add, and then shut myself down, with the literature on markets, where many people actually in favor or against market, I don't care in this specific setting, but they basically attack their opponents using non-ideal circumstances. And when it comes to actually advocate their theories, all of a sudden implicitly suddenly move to an ideal theory scenario, and that's, I think, is inherently unfair. So I agree with you. You mentioned some really relevant and up to the point consideration together with really great medical evidence, for which I'll be grateful actually if you can send. But on that specific point, I would say, fine, but these kind of consideration are relevant, but if we really take that into account, I'm not so sure they hold so much more against my proposal rather than randomization procedures.
Great. So Peter is next.
Yeah, and thanks, Ariel. And please let me know if I'm spending too much time on each of the answers because I don't see the list.
No, it's been very interesting so far, so I think it's been worth it.
Okay, hello there, Peter Stone, Trinity.
Oh, fantastic. Well, glad to see you, Peter.
Yes, you cite me a couple of times.
Yeah.
So I have about 1,000 things I could say.
I know.
I think the one that I think is most important here is this question of the idea of, you know, this move between ideal and non-ideal theory, which I think is incredibly important here. And I think that, frankly, you're using it in a way that lets you kind of like shift the goalposts wherever you want it to be. I'm worried that you might be doing that. Because, okay, we could talk at the level of ideal theory of just like, if in a world where we're omniscient and we can just know everything, are claims ever truly equal or something like that? And you probably know Nicholas Rescher's paper on choice without preference, where he gets into like the problem of like, you know, could God ever be in a situation where he's got two choices that are perfectly equally good and he cannot decide between them, and those, and how could he decide, and that kind of stuff. But that's a purely hyper theory kind of world. When we're dealing with the practical side of things, you talk about your proposal, but I'm not sure I understand what your proposal is. I mean, is the proposal to, I mean, if the proposal is just to say we should take into account claim strength as best we can, I don't know anyone in the lotteries literature who deny. I mean, I know most of the people, as you know, who say this. I don't know anyone who denies that. Of course, they would. I certainly never deny that. Of course, we should take into account claim strength, and we could. The question is, what happens when it looks like we've run out of competing reasons for distinguishing? And then I'm not clear: is the proposal you're making, we try again? Do we try again the third time? Do we try again the fourth time? Do we try again the 9th time? Is there a point where there's randomization? Because if you admit there is a point where there's randomization, well, then you don't have any principal disagreement with someone like me, certainly. I'm not someone who says, hey, just use lotteries everywhere. I mean, I'll say, sure, sometimes the claims are easy to distinguish. Sometimes they're hard to distinguish. Fine, I'm willing to let that be judged by the empirics of the situation there. So could you maybe say a bit more about what exactly the proposal is and how it's pushing back against what someone like me would advocate here?
Yeah, great. Thank you so much, Peter. I should add, I'm honored because, I mean, for those of you who do not know, you're one of the main players actually in the field, actually in lottery. You made a great book and papers before that on this very topic. So I'm really glad actually to have you in the audience. I will say a couple of things for now, and then we see how we go from there. So there are respects in which I think we do not have disagreements in principle there, in the sense that I would also agree that, and I think you're very balanced and explicit on that, both in your book and in your previous papers, that only a crazy decision maker will say, let's just use lotteries without considering anything else as the first thing we do. The point where we do disagree, I think there are at least a couple of issues where I think our opinion will tend to diverge. And let's see whether you agree with me, at least on the sources of disagreement. One is that the stage at which we should start implementing randomization procedures rather than trying harder with direct allocation procedures, and also how much resources and time and effort and money we should devote to that before resorting to randomization. And my sense from having engaged in extended reading of your great work will be that I will tend to actually admit randomization procedures in the picture at a much later stage, and only after having invested a substantively greater amount of resources in that kind of admittedly difficult exercise. And the second point, I think, is more a disagreement in perspective, I think. Namely that insofar as I can see, I see, so to speak, randomization. If we can think of a hypothetical continuum of justifiability, I think I'm trying to give you a physical picture to see whether I can drive the point more salient for everyone here. Is that randomizations to me are not the worst solution. I mean, they could easily be a second best, okay? They lie somewhere in the middle of that kind of continuum of justifiability, on the left of which we can think of plenty of admittedly bad, fallible, contested, and unsustainable direct allocation procedures. So I'm not a nerdy guy who advocate putting philosophers in charge, because philosophers that came up with crazy solutions were not informed by scientific practice. But at the same time, I would say that there are quite a few direct allocation procedures which sit on the right-hand side of that continuum kind of justifiability in such a way that my educated and probably informed and considerate guess is that I would advocate direct allocation procedures in many situations where you would actually advocate a randomization procedure. So that's the long story short, I would say.
All right, I think we have time for just one short question, and that would go to Charlotte, and then we have to wrap up, I think.
Hey there, thanks so much. Can you hear me okay? I've only just cool. All right, so I work in the UK, and one of the things I'm interested in is the constitution of our National Health Service. So it's a short question, just interested in that controversial point towards the end when you suggested maybe some kind of restriction according to desert.
Yeah.
I'm just gonna, I mean, I've thought about this, I teach this sometimes, but my thought, at least locally, is that we have to pay attention to the purpose of our medical institutions and the ethos of our medical institutions. And the NHS makes that helpful for me by having a constitution that says one of the things it's guided by is need, but it doesn't in any place put in the idea that it's guided by desert. It does say fairness, interestingly enough, so they might be open to some misinterpretation there, but I don't think in any sense our local institutions would be guided by desert ever. Just interested in your thoughts.
Yes, absolutely. I mean, Charlotte, it was more like a, let's put it like that, a frustrated rant by seeing how many people are flouting the rules that in the interest of the NHS was very constitution we all cherish. I'm actually seeing on the street in pubs and bars. So I would agree with you. I mean, my bigger concern there will be that it will be highly impractical actually to monitor and measure desert in situations like this. There are additional principal considerations, but honestly, on this point, given that we all know, I mean, in normal situations, I would agree with you. In this specific of public health emergencies, which is predictable with months in advance and we know what's going to happen if we don't behave in particular manner, honestly, I mean, I know that it's impractical, but in a purely kind of an ideal perspective, I would say, gee, there should be some kind of, desert-based indicator, if not at least for gently nudging people towards doing things that are not, when you take them in aggregate, have catastrophic outcomes, either on the NHS, or if you want to say the NHS, they will have catastrophic outcomes on the economy. So they are necessitating trade-offs that are incredibly damaging to all of us, which we could be able to avoid or at least alleviate if we could find ways of actually incentivizing people to behave in a more appropriate manner. Of course, at the point, I think that the most likely measures we can think from a public policy point of view is not a direct allocation procedure. I mean, we could easily implement these kind of incentives, not so much in the allocation scheme, but rather in other kind of measures of policy. I mean, you just increase fines massively, you go closer to the penal side of things. But the problem is simply just to say that kind of issue might not matter on the allocation itself when it comes to curing people, but is one of the relevant considerations that I would like to take into account when we know that if you behave in that particular manner, you end up in that solution. And I certainly don't want to arrive in a situation where I cannot be cured because 20 other people are lying ahead of me in a particular ambulance because they've been flouting these rules altogether. Of course, there is no zero kind of risk zero situation. We are all liable and vulnerable to this, but even more than I would say. In some situation of emergencies, it might actually be in favor of revising or augmenting the set of factors that might actually figure even in the constitution of bodies such as the NHS.
Awesome, thank you.
Thanks.
All right, thanks everyone. I think we're gonna have to leave it there, but I'm gonna unmute you all so you can join me in thanking Roberto for a really great talk. So thank you so much, Roberto.
Thank you so much to you, and thanks for the great questions, which I really appreciated, and they're actually helpful to invite myself to go for further round of reflections there. And if you have any additional questions that you didn't have the chance actually to ask me, I will be super grateful if you can actually send me your thoughts or some follow-ups in case any of the answers I have given actually during these talks are inconvincing or dramatically incomplete. So I will be really, really grateful for that.
Thanks so much, Roberto. And I hope to see you guys at some of our events in the future. If you're interested in checking those out, you can go to our website, which is philosophyinmedicine.org, and see what we're up to. So thanks so much again, Roberto.
Thanks to all. Thanks again, Ariette, for the fantastic
Bye.
event. Thanks.